Ankit, are we live?
One second, ma'am. Yes, ma'am, we are live now.
Hello and good evening, everyone. On behalf of Team ISPAE, I welcome everyone to ISPAE ACES Academic and Clinical Education Series 33. And today's topic is hypoglycemia beyond neonatal period. To all the delegates, I request them to put any questions in the Q&A section. And before we move further, I would like to invite our President ISPAE, Dr. Anurag Bajpai, sir.
Thanks a lot, Jalak, for this conduct of this wonderful program. And this has been one of the flagship programs of an Indian Society of Pediatric and Adolescent Endocrinology, in which we are trying to focus on recent developments in various aspects of pediatric endocrinology using interesting case-based discussions. So today, we are really honored to have Dr. Prateek Shah and Dr. Anna Simon as faculty for this session, and Dr. Sirisha and Dr. Ganesh as moderators, and two very interesting cases being presented by Dr. Fatima and Dr. Dolly on post-neonatal hypoglycemia. Now, this is one condition which really is intriguing. It is not that common as many of the neonatal hypoglycemia we have been seeing, and therefore it causes more challenges in terms of evaluation and management. So hopefully over the next 2 hours, we'll have a very intriguing session capturing these subtleties about evaluation and management. It's a pleasure to introduce Dr. Sirisha Kusuma, who is been actively involved in a number of ISPAE, ISPAD, and pediatric endocrine and diabetes activities across the country and in fact the globe. She is the consultant pediatric and adolescent endocrinology at Rainbow Children's Hospital, Hyderabad. She is the co-director of the flagship Ideal program, which is one of the wonderful program which is doing a lot of work in terms of pediatric diabetes awareness and empowerment in the country. She also is in the e-learning committee of the International Society for Pediatric and Adolescent Diabetes. She's also had been the joint secretary of ISPAE, has over 25 publications, and has been working a lot with regards to every aspect of pediatric endocrinology. So over to you, Dr. Sirisha, for this session, and please start with the moderation of the session. Thank you.
Thank you so much, Dr. Anurag, for the kind introduction. And thank you, Jalak, for introducing me to Dr. Dolly Mathan. For the next case, we have a very interesting case. So Dr. Dolly is assistant professor in pediatrics in ISPAE Hospital in Rajasthan. And she is a pediatrician with an interest in pediatric endocrinology and worked in the pediatric endocrinology department of Kalavati Saran under Dr. Anju Seth and Preeti Singh. So she is coming up with a wonderful case. So I'll hand over to Dolly, and then without any further delay, and then we can have a look at the case and then discuss any questions that may arise. Over to you, Dolly.
Thank you, ma'am. I'll just share my screen.
Dolly, we cannot see you. Can you turn on your video?
Yes, ma'am. Yes, ma'am.
Yes.
Good evening, all. So I'll be presenting the first case for today. So ours is a 18-month-old male boy, XYZ, born out of a non-consanguineous marriage, residence of Kasganj, Uttar Pradesh. The child first presented at 5 months of age with suspected seizures and was started on Levera outside, and the seizures remained uncontrolled and his dose of anticonvulsants were escalated. When he presented to us at around 6.5 months of age, his seizures were still uncontrolled and he had developed developmental delay. He was having no focus of sepsis, any fever, vomiting, diarrhea, or any other concerns apart from seizures. At this time, he was first found to have hypoglycemia. His blood sugar at our casualty was around 10. So it was sad that his blood glucose was never recorded since past few of days. In antenatal history, there was a positive history of gestation diabetes in the mother, which was managed conservatively by dietary modification. The baby was full term, normally vaginally delivered, with a smooth perinatal transition and a birth weight of 2.5 kg. At 48 hours of life, the baby developed neonatal hyperbilirubinemia with ABO incompatibility and discharged after 48 hours of phototherapy. The breastfeeding was initiated right after birth within the first hour. So there was no family history of seizures. There was a history of gestational diabetes in mother, but no other family had diabetes. The baby had global developmental delay in all the domains with the developmental age of 9 months at a chronological age of 18 months. The baby was exclusively breastfed for 6 months and then age appropriate complementary feeding was started. So, at first evaluation at our hospital, the baby was hemodynamically stable, afebrile, had no hemihypertrophy, omphalocele, macroglossia, umbilical hernia, or prominent earlobe creases. There was no micropenis or midline defect. No neurocutaneous markers were seen. No hyperpigmentation, no dysmorphism, rash, and the genitalia was normal. The systemic examination was also within normal limit. On evaluation of the blood glucose, by point of care glucometer, it was found to be around 10 milligram per deciliters. Seeing this, a laboratory confirmation of hypoglycemia was sent, critical sample was withdrawn, and an IV 10% dextrose bolus was given to the baby. Central venous access was obtained, and continuous glucose infusion was started at the rate of 8 mg per kg per minute, which require hiking up to 10 mg per kg per minute. So, the critical sample which was sent showed a blood glucose of 80, which was less than 50, with negative blood ketones. So this was hypoketotic. The cortisol and growth hormone response was not very good, but there was a detectable insulin. We did not do the C peptide and the free fatty acids. The lactate was normal, there was no acidosis, ammonia was normal, and urinary ketones were also negative. The urinary organic acids were not done. So, our child had a glucose infusion rate of more than 8, with the laboratory plasma glucose less than 50, with detectable serum insulin and low ketones. And rest of the investigation, like the CBC, CRP, LFT, serum electrolytes were normal. So, going forward with the algorithmic approach, our child had hypoketotic hypoglycemia. So, our main differentials were hyperinsulinism, fatty acid oxidation defect, hypopituitarism, hereditary fructose intolerance, and galactosemia. And the other differentials which have high ketones were hence ruled out. So, if the child would have had a fatty acid oxidation defect, the insulin should still have been undetectable. There were no midline defects, no micropenis, and there were no clinical stigmata of multiple pituitary hormone deficiency. So, hypopituitarism was also less likely. And there were the urine reducing substance was done, which was negative, and there were no other clinical pointers for hereditary fructointolerance and galactosemia. So, we could narrow down to hyperinsulinism. So, the point here is any baby with hypoglycemia with detectable insulin should have a high suspicion of hyperinsulinism. So this was our diagnosis. So we started the baby on diazoxide. We did a 2D echo at baseline, which was normal, and repeated it after 1 week, which was again normal, and continued at 5 mg per kg per day of diazoxide, and chlorothiazide was added along with diazoxide. Then a genetic evaluation was planned. The first genetic sample was sent at MDRF, which was negative, but still child has shown response to diazoxide, and hence we sent for a whole exome sequence. The whole exome sequence revealed a variant at the insulin receptor gene at exon 3. It was a heterozygous defect and was labeled as BUS. But there have been reports of heterozygous pathogenic variants in the insulin receptor gene. They are now recognized, although rare, cause of hyperinsulinemic hypoglycemia in children, adults, and even in occasional newborns. So ours is probably a novel variant. So this is the growth chart of our baby, how he's doing up in the follow-up. And this is his last anthropometry at 18 months of age. So this is the baby at 18 months, seizure free, although developmentally delayed, currently on diazoxide at 9 mg per kg per day with diazoxide induced hypertrichosis. No other side effects of diazoxide like pulmonary edema or pulmonary hypertension, hyperuricemia have been documented, and the CBC remains to be normal. So this is the last follow-up picture of the diary which the mother of the child has beautifully maintained, which shows there are records which are more than 100 and also some hypoglycemic records. We also did the parental evaluation. Surprisingly and interestingly, we found that the father's fasting blood sugar was low. Both the maternal BMI is 18.7 and paternal is 20.4. There is no acanthosis. There was gestation diabetes in mother, yes. And therefore, we have planned for parental genetics. So here, as our variant has been labeled as VUS, segregation analysis will give us the clue. So a little bit about the insulin receptor. So this is a schematic representation of the human insulin receptor gene, which is located on chromosome 19p 13.2, and it encodes insulin receptor, which is a transmembrane tyrosine kinase receptor, essential for glucose homeostasis, growth, and metabolism. And the INSR spans around 22 exons. So, as we are all aware, when the insulin binds to the alpha subunit, there is a conformational change which causes trans autophosphorylation of the beta subunit, and that recruits the insulin receptor substrate 1 and 2. This further activates the PI3K AKT pathway and leading to the metabolic outcomes, and the MAP kinase pathway, which activates to lead to the mitogenic outcomes. Interesting fact is that there is a tissue specificity with IRS2 being dominant in the muscle. So, in INSR mutations, the IRS2 is constitutively phosphorylated. There is increased binding of the kinase regulatory loop binding domain of IRS2 to the mutated receptor, and thus it is not being further activated by insulin or IGF-1. So, this kind of induces a peripheral resistance state in the muscle as compared to the liver, where the signaling is still preserved. So, this INSR mutation is basically a spectrum from heterozygous mild to moderate mutation to homozygous severe loss of function variants like Donahue and Rapson-Mendel syndrome, where there is a extreme insulin resistance, there is loss of this INS receptor, and when there is extreme insulin resistance, there is hyperglycemia. Due to the cross reactivity, some amount of insulin can activate the IGF-1 or 1 receptor, leading to fasting hypoglycemia. In contradiction, our heterozygous mutation, there is a dysfunction in the insulin receptor. There is insulinism, there is hyperinsulinism, but it is not as extreme as in the homozygous defects. There is a peripheral resistance, but the hepatic insulin signaling is preserved. There is also hypothesized that there is a reduced receptor number and function that prolongs the insulin half-life, and thus this leads to the postprandial hypoglycemia. So, just a visual representation that there is a peripheral resistance here in the muscles and the adipose tissue, and the hepatic effect will drive the hyperinsulinemic hypoglycemia, which will lead to decreased gluconeogenesis, increased glycogen synthesis, and hypoglycemia. So here is a paradox. There is insulin resistance, there is a hypoglycemia. So the core driver here is hyperinsulinism and with relative sparing of the liver. So the liver remains insulin sensitive, and reduced insulin clearance will further amplify the effect. So there are case reports regarding this mutation, and even neonatal reports have been found. This is the largest series which I could get from Sethi et al., where they have shown 3 families with newborns with being presented with neonatal hyperinsulinemic hypoglycemia. So this is a snapshot from their case series also. So key points which they could appreciate from the series was that there was no insulin resistant features in the family. So the different mutations may probably have a different phenotype, and even within the members of the same family, there can be a variable clinical phenotype. And all these newborns here, they were SGA. They showed a good response to diazoxide, and eventually the hypoglycemia resolved, and medication could also be stopped in some. Other case reports, there are adolescents and adults, and yes, insulin resistance has also been reported, and here they have used metformin probably to counter the insulin resistance, but actual mechanism is still unclear and needs to be studied more. So definitely diazoxide, metformin, is the treatment modality. So another thing which they have highlighted is that there is effect of high level of insulin on the type 1 IGF receptor in the neonatal period with subsequent resolution of hypoglycemia due to beta cell exhaustion. And then there are potential developmental changes in the expression of IGF-1 receptor also. And in the adult stage, they will have deposition in the pancreas following the chronic insulin resistance, and that leads to type 2 diabetes. So some cases may not be responsive to diazoxide also. So as being highlighted in these case reports. So what else can be done? So we can give small frequent feeds, avoidance of prolonged fasting, use of uncooked cornstarch, and in refractory cases, consideration of somatostatin analogs. What long-term follow-up do we need? Majorly of these will develop the signs of overt insulin resistance later on in their life, maybe impaired glucose tolerance, frank diabetes, and dyslipidemia, and features of type A insulin resistance. It is very important to track the neurodevelopmental outcome of these children, especially if they have insult in the early period of infancy, as in our child who still remains to be developmentally delayed. So the take home messages: think beyond the standard congenital hyperinsulinism panels, consider insulin receptor mutation testing in CHI panel negative cases, confirm whether the insulin receptor is included in your labs panel. The sequencing is now a part of the extended panels, especially when there is a coexisting insulin resistance or family history of diabetes. So please confirm with your lab, and it will have a broad clinical spectrum which will range from hyperinsulinemic hypoglycemia in infancy, childhood, to insulin resistance and hyperglycemia later in life. Family history is the key. Look for mixed pattern of hypoglycemia, diabetes, insulin resistance across generation. Thank you.
Thank you so much, Dolly. That's wonderfully done, and have nicely explained the insulin receptor, how at the same time the insulin receptor mutation can cause hypoglycemia with coexisting insulin resistance. I don't see any question and answer so far. Zala, any questions in the chat box or Q&A?
No, ma'am. No,
Do you
no.
see any? No.
Our experts, if they want to comment.
Yeah, so if any panelists have any experience, Dr. Pratik, Dr. Anna Salman, ma'am, any experience, because I think only maybe 200 plus case reports are there. Yes, Dr. Pratik.
Yeah, hi. Thank you very much, Dolly, for a very nice presentation. So just wanted to ask a couple of things. One, you showed the blood glucose diary. Was this pre-feed blood glucose or a post-feed blood glucose?
It's a pre-feed blood glucose.
Okay, so you've very nicely highlighted, and actually you've taken, I'm not going to say much, but you've taken one of my cases anyways, but the one that I'm going to discuss later, mainly is, like you mentioned, there's a postprandial hypoglycemia. So generally, children with insulin receptor mutation would be able to fast overnight, generally. Occasionally, you may need to give cornstarch. So, very rarely that, they will be able to have hypers, but if needed, you can give cornstarch at bedtime.
Yes, sir. Yes, sir. We gave a few of the time we gave to our patient also.
You gave that.
Yes, sir.
So because I'm just kind of thinking about this way, it's like, because the diazoxide dose is 9 milligrams per kilo per day. And generally, if we look at the diet, if we can try and look into diet, the general diet advises that you avoid pure carbs, avoid, so what you normally do is give a little bit of protein or fat, then carbs, and then give protein and fat. So your meal should consist of carbs in the middle and then protein and fat, before and after the carbs. And trying to avoid large amount of carbs, which is what happens is when they have postprandial hypoglycemia, and that is what happens with insulin receptor mutation. So if we can work on those diet, because obviously right now they're doing pre-feed blood glucose levels, what we would not know if they have a post-feed or postprandial hypoglycemia. So what I tend to do is with my, parents, what the families I ask them to do sometimes pre-feed, but I'm more interested in post-feed blood glucose levels. And obviously one in the morning, which is fasting blood glucose, because that's the most important thing. You want to know whether they are able to fast appropriately or not. And depending on, again, the response, yes, diazoxide is one of the treatment options. But sometimes, depending on the side effects, and if you feel that they are having increased hypertrichosis or something, we can always try and either modify with diet, cornstarch, and I've also got Ecobos. I've used Ecobos in children, which helps to delay the absorption of carbohydrates. So basically, it avoids the postprandial hypos. So you can also try that Ecobos. And obviously, eventually, this child will come off medications and then develop like diabetes, like a type 2 diabetes picture. Um, but it's very nicely shown as what you've said, the mechanism. I think that's really important in insulin receptor mutation, is to understand the mechanism and what kind of hypoglycemia that occurs. It is not a simple like a fasting hypoglycemia in these children. I mean, they can have it occasionally, but mainly it's a postprandial that we need to look for.
Thank you, sir. Thank you so much for your input, sir.
So were you able to manage any kid without, I mean, any infant not on any medication, only feeding management and
With insulin receptor,
with INS, sir?
yes.
Yes, okay.
So it's very interesting now how the insulin receptors. So we actual moment, we're doing a large international case series. It's I think we've got about 300 or 400 children across the world, and it's how they present is that some babies do present with fasting hypoglycemia. It's the main issue is the fasting hypoglycemia that you may have to give medications for if if they have fasting. But if they have postprandial hypoglycemia, then the first treatment of choice would be the feeds. Try and work at around the diet and the feeds. The second thing would be cornstarch, if you can give cornstarch, because it's just that the postprandial hypos that can be avoided. And then obviously you then try Ecobos or diazoxide. So depending on the age. So yes, so we try and look at the severity, and that's what Dolly's presentation was very interesting, is the severity, how they actually vary. Some of them are quite severe, some of them are very mild. So it all depends on the frequency of hypos, the type of hypos, and then we decide the treatment, that whether they can just manage on the feed or dietary modification, or do they need medications.
Right. So low glycemic index kind of diet, pretty much, and
Yeah, or I mean, not like typical low GI, yeah, but you could do that, and as well as thinking about giving as a mixed meal. So trying to avoid like pure carb.
And what's the youngest age you would say, like cornstarch, they say before 9 months, the ability to digest is pretty low.
Yeah.
There's no
So
point of.
we don't use below 2, but I know that in other countries they use, in sort of after 6 to 8 months of age. The only issue is constipation. So it does become a bit of a difficult thing. But people have used glycosate. So, if you do get glycosate, then you can use glycosate as well.
Right. Yeah. Any comments, Anna ma'am? Thank you so much, Dr. Pratik. It's very interesting.
Yeah,
I think
that
there
was
was a
really.
question how. Yes, ma'am.
No, I have no comments. Agree with Dr. Pratik Shah. Yes.
Yeah, it's pretty rare condition. I haven't seen any like this is the first time Dolly has introduced me to INSR mutation. And
Yes, there is a question, ma'am.
yeah, so how to manage feeding intolerance due to diazoxide? It's a general question, I guess. Feeding intolerance due to diazoxide. So as far as I know, generally the feeding intolerance is more of an issue with the octreotide. I mean, I'll just invite Dr. Anna, Dr. Pratik to throw any light like on this. There is any known risk of feeding intolerance with the diazoxide per se?
Do you want me to mention? Do you want me to answer?
Yeah, because as I mean, feeding intolerance I haven't come across, and that is not a known. NEC is a rare complication, but I would rather consider more it with octreotide and in extreme premature babies. But do you see feeding intolerance commonly with the diazoxide?
So yeah, I mean, so basically, diazoxide is known to cause suppression of appetite, and we do see that in especially younger children. And that is why I was, kind of trying to say that maybe if, sometimes we may have to reduce the dose of diazoxide, in this group of children where, just a bit of dietary modification may help. So unfortunately, there is no clear sort of answer that how do we really do it. It can suppress appetite, and sometimes we just have to manage in such a way that we are giving appropriate nutrition and making sure the child is gaining weight. And hence, it is really important for us to review this blood glucose regularly and understanding that the mechanism of hypoglycemia. Because just based on just one hypo, post feed hypo, if we keep increasing diazoxide, that also wouldn't be right, because you could just manage a little bit of the diet or feed. So it's always important that, when we actually follow up these children, we understand what is the mechanism of hypo and when the hypo is, and can we try and manage with other treatment options rather than just increasing diazoxide.
Yeah. So I guess in younger baby, like if I think Bhakti asked the question, if you're asking about neonate probably having feed intolerance, inability to reach the feeds, of course we do consider gastrostomy, and that's a pretty standard.
Yeah.
In severe cases, unable to manage, but in older kids, probably like Dr. Pratik was saying, managing between feeds versus diazoxide dosing, balancing between those two. Any other questions, Alok?
No, ma'am.
Should we move on?
Yes.
Yeah, thank you so much. Thank you, Dr. Pratik, for the discussion. Nice discussion. Thank you, Dolly, for the excellent presentation. Thank you, Zalak. And then the next, next session is by wonderful Dr. Anna Salmon, ma'am, who needs no introduction, but it's my privilege to introduce ma'am. She's professor in pediatrics and a consultant in pediatric endocrinology and metabolism with decades of experience and more than 50 publications in peer-reviewed journal. And she's going to give the next presentation on postnatal hypoglycemia. Over to you, ma'am.
Shall we start?
Yes.
ma'am.
Yes.
Okay, so forever this hypoglycemia definition is always a bit difficult to do, but what is hypoglycemia? How do we think of hypoglycemia? I think plasma glucose concentrations, which are very low, enough to elicit defensive neuroendocrine responses and or signs of impaired brain function. So the fallacies here is that, of course, most of the signs and symptoms are non-specific, and you can't rely on a single low plasma glucose concentration. And point of care glucose meters, the accuracy is limited to plus or minus 10 to 20 especially in the hypoglycemic range. And if you're looking at whole blood glucose levels, they're approximately 15% lower than the plasma concentrations. For these reasons, I think the Pediatric Endocrine Society has put up these guidelines where they emphasize the value of using a Whipple's triad. A Whipple's triad consists of symptoms and or signs consistent with hypoglycemia, a documented low plasma glucose concentration, and relief or resolution of the symptoms and sign when the plasma glucose is restored to normal. And as you all know, infants and young children cannot communicate their symptoms, so this cannot be applied to all of them. And we may have to resort to repeated measurements of plasma glucose concentration and sometimes even a formal provocative testing. So who should we evaluate for hypoglycemia? I think older children and adolescents who will demonstrate the whole of Whipple's triad, and younger children, infants and younger children who cannot communicate symptoms, maybe when the plasma glucose is less than 60 milligram per deciliter on laboratory quality assays, not based on the glucometer assessment. You could say that in inability to maintain plasma glucose more than 50 in the first 48 hours or more than 60 after 48 hours also makes them eligible for evaluation for hypoglycemia. So glucose homeostasis actually depends on a few processes and some requirements are there. So if you understand the processes involved with glucose homeostasis, once there should be proper GI absorption, the normal glycogen storage, and there should be breakdown of the stored glycogenolysis, and there should be de novo synthesis, gluconeogenesis, especially during the fasting states. This requires supply of substrates, a functionally normal liver, normal metabolic functions, and normal endocrine functions. So hypoglycemia can occur when any one of these processes are involved. The physiology of fasting, of glycemic control, and with fasting and in the postprandial state, I think this everybody is quite used to this diagram and this thing. So in a postprandial state, in a fed state, insulin is released, and insulin causes increased glucose uptake, glycolysis, glycogen synthesis, triglyceride synthesis, and protein synthesis, an anabolic hormone, and decreases the other process of glycogenolysis, gluconeogenesis, ketogenesis, beta oxidation, or proteolysis. But when we move on to the fasting state, as you can see here, at the first 2 to 4 hours, glucagon starts being secreted, followed by epinephrine, cortisol, and growth hormone, which reverses the process and encourages glycogenolysis, gluconeogenesis, beta oxidation, proteolysis, and ketogenesis to keep this glycemia between 70 and 100 milligrams per deciliter. So it differs with age groups. When these processes, the lower the age group, I think the processes are a little more earlier, and you cannot fast for long before you reach hypoglycemia. And you can see an adult can fast up to 48 hours and still maintain normal glycemia, can maintain euglycemic levels. So this picture, I think I'm not going to evaluate more on that. And so the same thing over here. Whenever you're fasting, insulin levels drop, especially when the plasma glucose is less than 80. And then it causes endogenous glucose production like glycogenolysis and gluconeogenesis to maintain euglycemia. And in the second part of the fasting state, we have all these hormones which are released, which will help with glycogenolysis and increase glucose release, gluconeogenesis, and lipolysis, resulting in increased fatty acids and ketogenesis. So the fasting time, we have to realize that the fasting time is lesser as the age decreases. And the physiology of fasting, this is especially for the critical sampling, is less than 100, between 70 to 100. And the target for treatment is also to reach a level of 70 to 100. And we have to exercise definite caution below 50. It's a point for terminating any kind of provocating test, and you start getting symptoms, neurogenic and neuroglycopenic symptoms below 70 milligrams per deciliter. So what are the signs and symptoms? You know, all of you are very familiar with this. Neurogenic symptoms, which is basically following the adrenergic response, epinephrine, cortisol, growth hormone, and you get a set of symptoms which we have to realize. And also there are neuroglycopenic symptoms when the brain function is impaired and which is moving on to a dangerous phase. At the time, all provocative testing has to be stopped. Now, the causes of hypoglycemia, the endocrine causes are mainly hyperinsulinism. As we said, congenital hyperinsulinism, which can even occur beyond the neonatal period. Exogenous insulin, some other medications which can release insulin, insulinomas, and syndromic forms. IGF-2 production in children with hepatoblastomas, large mesenchymal tumors, WIMS tumors, and Hodgkin's lymphoma can also result with, it's an insulinomimetic molecule, so it attaches to the insulin receptors and cause the same kind of responses and cause hypoglycemia. And you all know that the counter-regulatory hormone deficiencies, cortisol deficiency, growth hormone deficiency, or glucagon deficiency, and also result in hypoglycemia. If you look at the metabolic causes of hypoglycemia, they are also into 4 categories. One is the disorders of hepatic glucose release, mainly the glycogen storage diseases type 0, 1, 3, 6, 9, and 12, hereditary fructose intolerance, and galactosemia. Disorders of fatty acid oxidation defects like carnitine cycle, beta oxidation defects, and ketogenesis. Disorders of gluconeogenesis have to be considered. Fructose 1,6 bisphosphatase deficiency, pyruvate carboxylase deficiency, phosphoenol pyruvate carboxykinase, and other metabolic defects, especially mitochondrial respiratory chain defects. So how do we approach hypoglycemia? First of all, when we are trying to assess and evaluate a patient, we have to look at the age of onset, whether it is a neonatal period, infancy, or childhood. The perinatal history is very important, especially with the neonatal hypoglycemia, but it still holds importance in later hypoglycemia also, because the gestational age and the weight at birth, other forms of perinatal distress, perinatal glucose requirements may also have some saying in the cause for later hypoglycemia. Growth and developmental milestones are very important. Intellectual disability, movement disorders, and epilepsy, they may point to a specific diagnosis, especially some of the inborn errors of metabolism, and including, I think, vision, cortical visual loss, or any imaging like MRI imaging showing occipital changes with hypoglycemia comes very relevant to finding out a cause for hypoglycemia. So it's very important that we reach a good diagnosis before we plan treatment. Family history related with hypoglycemia, previous miscarriages, consanguinity, medication, and fasting tolerance, the feeding frequency, night snacks, morning ketosis. It will be always important to know the time to having hypoglycemia also helps in getting to a good diagnosis. So the temporal relations with feed, like fasting, is it fasting hypoglycemia? Is it a postprandial hypoglycemia, or is it random? Or avoidance of any food, and is there relation to any food like a protein, a specific protein, like lysine sensitivity or fruits or galactose and lactose, and always check on the associated conditions and triggers what causes hypoglycemia. The physical examination will also help in detecting whether it's an endocrine dysfunction or an inherited metabolic disorder. Like if you are looking at hypopituitarism, micropenis, short stature, adrenal insufficiency with hyperpigmentation, weight loss, muscle pain, and if you have hepatomegaly, you think of glycogen storage disorders. If you have cataract and jaundice, you think of galactosemia. Absence of dental caries may point to hereditary fructose intolerance. Heart problems, arrhythmias, you look at fatty acid oxidation disorders, movement disorders, and more of neurological involvement, organic acidemias. Or if you have inverted nipples, buccal pad of fat, hypotonia, you look at CDG group of disorders. If it's multi-system involvement, you would consider mitochondrial disorders. And of course, there are overgrowth syndrome, syndromic causes of congenital hyperinsulinism. So we look at all those as well. They give a pointer to get a diagnosis of hypoglycemia. So what are the investigations that we'll do? Collecting a critical sample is crucial for diagnosis. Many of the time, the critical sample is missed whenever patients come to the emergency. So it's good to know that all pediatricians who are in the emergency should collect a critical sample if a child presents with hypoglycemia before managing the hypoglycemia. And sometimes that's what. So if you don't get a critical sample and an episode of hypoglycemia, you have to induce hypoglycemia by a diagnostic fasting test. A critical sample should be sent for analysis of blood glucose, lactate, pyruvate, ketones, ammonia, the blood gas. So whether there's acidemia or not. If you can do free fatty acids, that will be helpful. Insulin, C-peptide, cortisol growth hormone. And in addition, it is also good to look at the acyl carnitine profile and urinary organic acids. So the diagnostic fasting test, this is the duration of fasting which is given in Sperling Pediatric Endocrinology 5th edition. But in my practice, I don't think we have ever done a fasting test less than 1 month. Generally, we would do it only after 3 or 4 months of age. And our fasting times are much shorter from what has been said here. Anyway, we can start fasting. At the first beginning, we check plasma glucose every 3 hours. And once the plasma glucose is less than 70, we keep monitoring every 1 hour. And once the plasma is less than 60, then you have to be very careful. You monitor every 30 minutes. And an ideal sample is a plasma glucose of less than 50. This is not the glucometer value. This is the lab value that should be less than 50. And then you collect a critical sample. So it has to be performed in very specialized areas where there is good monitoring, and then you can get the laboratory results within 10 minutes back before you collect the critical sample. The maximum duration, this is based on the patient's age, and also the local practices may differ. And the plasma glucose less than 50 milligram will be very good, or if the patient is symptomatic, we'll have to abandon the test and collect the critical sample. So these are the flow diagrams which are available in Sperling also. Once you confirm hypoglycemia, and then you can go by the algorithm if there is acidemia or if there is no acidemia. And again, if there is increased lactate, acidemia and increased lactate, then you think of certain conditions. If there is acidemia and increased beta hydroxybutyrate, you would think of other conditions. I'm not going through all that. I think all of you are there and you have all seen that. And when there's no acidemia, you would consider, and the free fatty acids are low and the ketones are low, you would consider disorder of insulin secretion. There are multiple etiologies under that category. But if the free fatty acids are high and ketones are low, you would consider disorders of fatty acid oxidation or ketogenic defects. The other way to look at this is hypoglycemia. Did it happen fasting? Did it happen postprandial? Did it happen random? And you know how to assess the postprandial. The classical conditions where you have postprandial hypoglycemia is hereditary fructose intolerance, galactosemia when you are fed a galactose-containing diet, or an organic acidemia where you take a high-protein diet and you may precipitate a postprandial hypoglycemia. You can add the insulin receptor heterozygous state to this postprandial hypoglycemia now, I think. And factitious causes of hypoglycemia and hyperinsulinism again can happen randomly. If it is fasting, the first thing that you check is ketones. And if ketones are low normal and metabolic, they check whether there is acidosis. If acidosis is not there, then it's hyperinsulinemia, or it can sometimes be hypopituitarism in the newborn. But if you have metabolic acidosis and the free fatty acids are checked. If the free fatty acids are low, it will be GSD1. If the free fatty acids are high, then you would think of oxidation phosphorylation defects, fatty acid oxidation defects, or ketogenesis defects. If we have high ketones and metabolic acidosis, and then you check whether the lactate is high or not, in the low lactate levels are ketotic hypoglycemia of childhood, GSD0, ketolysis defects, and adrenal insufficiency. If the lactate is high, you're looking at fructose 1,6 biphosphatase deficiency, organic aciduria, or pyruvate carboxylase deficiency. So the clues to diagnosis when we are in the hospital and we are trying to diagnose hypoglycemia, sometimes it may not be easy. Hyperinsulinism usually is easier to diagnose. You have a child who is thriving very well and a very short fast time, and you get a clue quickly with high levels of insulin, unsuppressed insulin with hypoglycemia. So the other clues to diagnosis is amount of glucose needed to treat the hypoglycemia, the timing of hypoglycemia, as we will come to it now. There is that presence or absence of ketones, the liver size, and the presence of lactic acidosis will help you to determine the cause. So timing of hypoglycemia, if the hypoglycemia occurred in less than 2 hours following a meal, it is most likely hyperinsulinism or dumping, or now that we know that insulin resistant states, the heterozygous state, hereditary fructose intolerance if you are having a high fructose diet, and galactosemia. And the reasons are, it's already given there. In the first condition, it is insulin, whether it's hyperinsulinism or dumping or insulin resistant states, or in hereditary fructose intolerance, there is decreased phosphorylation and there will be no entry into the gluconeogenetic pathway. And galactosemia, there is obviously liver dysfunction, which will promote hypoglycemia. If it is 2 to 4 hours, again, it can be hyperinsulinism, but also the GSDs 1, 3, 6, and 9 come. In 4 to 8 hours, it is again hyperinsulinemia. You can see that hyperinsulinemia can occur any of these groups in different forms, and the conditions are mentioned there. And more than greater than 8 hours also, we have to think of these conditions which are grouped together. So the timing of hypoglycemia is a very important factor that we have to take in the history while we are looking at these patients. The other important aspects which would help is hepatomegaly. If there is hepatomegaly, you consider GSDs, except GSD0, Fanconi Biggle, and also you can have hepatomegaly in fructose 1,6 biphosphorase deficiency and fatty acid oxidation defects during acute decompensation. The presence of lactate usually points to a mitochondrial disease or pyruvate carboxylase deficiency. Sometimes the lactate levels can differentiate between GSD1 and the other deficiencies because fasting lactates are high in GSD1 And in the other GSTs, lactate may elevate postprandially, but the fasting lactate helps to differentiate GST1 from the other GSTs. And it's also high, lactate is high in fructose 1,6 bisphosphonate and certain urine organic acidemias. So the endocrine causes, of course, the most prominent cause is hyperinsulinemic hypoglycemia, and it's the most severe form of hypoglycemia also, and most difficult to treat as well. So you know that, and there can be different types: transient, congenital, syndromic, or miscellaneous. I'm not going to go into detail of that. All of you are aware there are transient causes, and there is a lot of genetic causes of hyperinsulinemic hypoglycemia, which has been published. This is an old publication. So the diagnostic features for hyperinsulinemic hypoglycemia are a glucose infusion rate more than 8 milligrams per kg per minute, extremely low values of plasma glucose with detectable serum insulin and C-peptide levels, a low beta hydroxybutyrate, low free fatty acid, and a good response to glucagon will almost give you a diagnosis of hyperinsulinemic hypoglycemia. Commonly, they present with well-thriving child, persistent and recurrent hypoglycemia with high requirements, and there may be characteristic features in syndromic forms. The syndromic forms of hyperinsulinemic hypoglycemia, there are two categories. One is with overgrowth and macrosomia like Beckwith-Wiedemann, Sotos, Simpson, Golabi, Behmel, or Perlman, and some with postnatal growth failure like Kabuki and Costello, which have very specific clinical characteristics. So the other causes is deficiency of growth hormone and hypopituitarism, can be isolated or multiple pituitary hormone deficiencies, usually occurs in early infancy or in toddlers, and you can detect midline defects, other ocular craniofacial anomalies, micropenis with undescended testis, prolonged and recurrent jaundice in infants. There will be growth deceleration during the first year of life. Diagnosis can be made by a growth hormone stimulation test, and you have to always evaluate for other pituitary hormones, and you can do MRI to help further confirming the diagnosis. So growth hormone resistance and insulin-like growth factor 1 deficiency also can cause fasting hypoglycemia, and it doesn't improve by giving growth hormone, but these tend to improve in adolescence, but even in adolescence can occur with prolonged fasting.
Ma'am, the presentation has stopped. Did you stop it?
No.
Yes, ma'am. We cannot.
You cannot see it?
Yeah,
No.
can you redo the screen share?
1 minute. I'll have to come off. I don't know what happens. 1 minute.
Zalak, do you want to share or just
Yeah.
keep?
Wait, I don't have ma'am's presentation. It doesn't happen in answer.
Good. Sorry about that.
Yes, that's okay. Yes. Slideshow.
Can you see it now?
Yes, yes.
Yes, yes.
Okay, so deficiencies of cortisol and ACTH also can result in hypoglycemia, because cortisol is important for mobilizing free fatty acids for gluconeogenesis. Cortisol deficiency also present during neonatal, infantile, childhood, any age group, and it usually occurs after prolonged fast. And associated findings would be anorexia, weight loss, abdominal pain, headache, nausea, and sometimes they present even with an adrenal crisis. And in primary adrenal causes, you would have the available test of cortisol ACTH, the stimulation, or the most common ones at CH21 hydroxylation, 17 hydroxyprogesterone levels. The metabolic causes of hypoglycemia, there are many, as I said, the GSDs, and each GSD has particular features. GSD 0, 1A and 1B, you have hyperuricemia, hypertriglycemia, along with fasting hypoglycemia and ketosis. And in 1B, you do have failure to thrive, neutropenia, and inflammatory bowel disease. So these are the other GSDs which result with hypoglycemia. We're just mentioning them there. And most of them have characteristic features for diagnosis. And of course, genetic test doing a clinical exome or so can confirm the diagnosis. And disorders of gluconeogenesis, they will fall into fructose 1,6 bisphosphatase deficiency, pyruvate kinase, pyruvate carboxylase, phosphoenol pyruvate carboxykinase deficiencies. And they also can be identified by their specific biochemical features and some clinical features which are there. Pyruvate carboxylase usually have severe encephalopathy, developmental delay, and growth retardation. Other metabolic disorders which cause hypoglycemia are hereditary fructose intolerance, aldolase B deficiency, galactosemia, organic acidemias, and free fatty acid oxidation defects. And they have particular clinical features, like when you see exercise and all, cardiomyopathies and arrhythmias, you would think of fatty acid oxidation defects, whereas movement disorders, renal disease, and encephalopathy would think more of organic acidemias, and galactosemia, as you all know, hepatomegaly, liver failure, cataract, and postprandial hypoglycemia will be seen. So ketogenetic defects like HMG-CoA lyase deficiency or ketolysis defects also with prolonged fasting result in hypoglycemia. Most of them are characterized by hepatomegaly and sometimes cardiomyopathy in few of them. And you can make a diagnosis by the urine organic acid abnormalities, and some hyperammonemia is present in a few of them. Then multisystem involvement is usually seen with mitochondrial diseases, and you can make a diagnosis by looking at, again, urine organ and multiple abnormalities which can be present. Ketotic hypoglycemia of childhood is one of the most common type of childhood hypoglycemia. Probably there are multiple reasons behind this, but typically at 1.5 years to 5 years, and the resolve as a child becomes older, and it's a diagnosis of exclusions like beta blockers or salicylate intoxication, falciparum malaria, postprandial hypoglycemia like in dumping syndrome. We already talked about that. And prolonged fasting, starvation, even in healthy children, can deplete hepatic glycogen stores and cause hypoglycemia. Stressful illness, rewarming after hypothermia, near drowning because of increased metabolic demand can result in hypoglycemia. Chronic malnutrition, depleted glycogen stores, prolonged intense exercise, increased muscle glucose utilization, and acute diarrheal illness, reduced intake and substrate depletion again leads to ketotic hypoglycemia. Thank you.
Thank you so much, ma'am, for such a wonderful and elaborate presentation that covered literally every single etiology for hypoglycemia in the infants and later childhood. We'll see if there are any questions. There's one question in the chat box. Dr. Aruna is asking, is there a need to do both insulin and C-peptide?
I don't think so. It may help to distinguish between exogenous insulin administration. If you are doubting it, then you can do that.
So
If the
I
child
may add,
is
recently we
secondary
had
to
a
some
case.
medication,
Yes, ma'am. If I may
secondary
add,
to medication or
Yes.
insulin, yeah.
So recently we had a case of trisomy 21 presenting to emergency with severe hyperinsulinemic hypoglycemia and very low C-peptide. So So we have to think about medical legal issues. So especially for
Yeah.
cases who are presenting to emergency. But I
Yeah.
guess Dr. Pratik might know more with regards to cases that happen in NICU also, because there's a case going on in UK, as far as I know, uh, uh, to advocate for doing a C-peptide along with insulin for factitious hypoglycemia.
Yeah, so we generally ask lab to process both. And also in IUGR babies and SGA babies, we do see sometimes, because in C-peptide has got longer half-life. So we do see sometimes that insulin is low or undetectable, but C-peptide. So we generally say more than 100 picomoles per liter of C-peptide is generally kind of suggests that there is some detectable insulin around. So we've had babies where they typically behave like hyperinsulinism, the SGA babies. The insulin will be undetectable, but C-peptide will be more than 100. And plus, then you have low fatty acids and low ketones, which will then point towards diagnosis of hyperinsulinism. So it helps both ways, obviously from factitious illness as well. And interestingly, I was discussing with one of our colleagues in India as well, and it turned out to be factitious as well. So it does happen, and I think you just have to keep open mind.
I would say definitely if we are evaluating recurrent hypoglycemia in a child with type 1 diabetes, sometimes they complain of hypoglycemia even apparently without insulin. And that is one scenario where I would definitely do it. Second, as Shirisha and Pratik just pointed out, just today we are dealing with someone, an infant with hypoglycemia who has a detectable, insulin, but low C-peptide. So I would say that it would be useful to get it both done if possible.
And given the inherent problems with insulin, it's always better if you want to really evaluate whether C-peptide does give a clue, even if you're talking about conventional hyperinsulinism, not just the factitious one. C-peptide is always better because often the insulin will be unreliable in those regards. And I think other parameters, as Pratik said about beta hydroxybutyric fatty acid, I would say C-peptide is a very good marker in that perspective.
Thank you so much, Dr. Anna. Zalak, any more questions? Otherwise, I think
No
we
question.
move on to the next session. We move on to the next session. I'll hand it over to, shall I introduce?
No, Anurag sir.
Okay, I'll hand it over to Dr. Anurag. Over to you, sir.
Thanks a lot, Dr. Shirisha and Dr. Dolly for the wonderful case discussion, and Dr. Anna for the wonderful presentation. It's now my pleasure to introduce Dr. Ganesh Javelika, who really doesn't need any introduction from an Indian pediatric endocrine setting. He is working as pediatric endocrinologist at Max Healthcare as the Director Pediatric Endocrinology there in Saket and Gurugram. And he has done extensive research work with regards to pediatric endocrinology, including multiple publications, book chapters, and also being part of the hypoglycemia and type 1 diabetes guidelines by ISPAD. And he is also our own congenital hypothyroidism guidelines. He was one of the editorial committee members. So over to you, Ganesh, and we hope we'll have a very good discussion on this case with Dr. Fatima. Thank you.
Thank you very much, Dr. Zalak and Dr. Anurag, for inviting me here. And I think without wasting any further time, we'll go on to the case presentation. So the case will be presented by Dr. Fatima Bibi. She hails from Kerala, and currently she's doing a PICU fellowship at Apollo Hospital, Chennai. Am I correct, Fatima? And she's working with Dr. Saundara, who is one of our very important colleague of pediatric endocrinology. She's going to present an interesting case. What we will do is that as she starts presenting, at the end of history and examination, we will take one pause and we will just see if there are any questions or comments at that stage. And then once she completes the case discussion, we'll have another round of discussion. Over to you, Dr. Fatima.
Thank you, sir.
I think we have drawn her out of her Eid celebrations to present this case. So we can all wish her Eid Mubarak and wish everybody Eid Mubarak actually.
Thank you, sir. It was yesterday in Kerala. It was yesterday, so I'm happy today. It was like not today.
We can
Can you
see your
hear me?
slides. We can see your slides. You can start presenting.
Okay. Good evening. Today I'm presenting an interesting case regarding hypoglycemia. And first, initially, I want to thank you, Saunthara ma'am, for giving me this opportunity and guiding me throughout. Also, Ganesh sir for helping me with this presentation. So, when hypoglycemia defies a clinical conundrum. So starting with the case, we are presenting with a 10-year-old male child who was brought with the complaints of 2 episodes of generalized seizures. First episode was 2 days prior to the presentation. He was diagnosed to have severe hypoglycemia from the local hospital, and he was given dextrose containing fluid and was referred to our hospital. On the way to our hospital, also, the child had the second episode of seizures, which lasted nearly for 15 minutes till reaching ER. But there is no history of any fever, loose stools, vomiting, or any other previous history of headache or vomiting. There was a history of weight loss nearly 5 kg for the last few months, according to parents. And the child is also having recurrent abdominal pain for the last 1 year. In the past history, there is no previous history of seizures, but there is a history of appendicectomy was done 6 months back, and child was diagnosed with hyperoxaluria type 1 1 month prior to the presentation. It was genetically proven also, this hyperoxaluria, and it was type 2 hyperoxaluria. Birth history, he is the first born child of a non-consanguineous marriage, and birth weight was 2.6 kg, and there is no history of any ICU admissions. No, and he's developmentally normal. Family history, there is a history of type 1 hyperoxaluria in the father, and he was underwent renal transplant, but however he expired 7 years back, and now child is living with mother and father. On arrival to our ER, the child was maintaining airway, respiration was okay, regular respiration, and saturation was maintaining, and hemodynamically his perfusion was normal, and GCS was little low, but he prefers to sleep, and febrile. On checking on point of care investigations, initial blood gas showed normal pH, bicarb was also normal, but the glucose was less than 20 in the initial presentation. Lactate was also normal. So, initial physical examination, his height and weight was normal between the 90th, height was the 97th centile, and weight was also adequate, and his BMI was between the 50th centile and overweight centile. And there is no facial dysmorphism. And on systemic examination, there is no hepatomegaly. Abdominal, some scar was present over the abdomen. Previous appendicectomy scar was there. And neurological examination was normal, and other systems were within normal limits. So we proceeded with the evaluation. Critical sample was sent, and random sugar was 16 at the point, and blood gas was.
Dr. Fatima, can we stop for a minute?
Yes, sir.
And if you can go back to the previous slide. Based on this clinical picture, would you summarize the clinical picture and think of possibilities before we go on to the critical sample results?
Yeah. This is a 10-year-old male child with type 2 hyperoxaluria and presenting with hypoglycemia and sudden onset of hypoglycemia. Previously, there is no history of any hypoglycemia, and his weight, there is a history of weight loss also for the last few months, according to parents. So, but on examination, as his weight chart, his BP, weight was adequate and height was also normal. So, we were thinking of any sudden means malignancy because of insulinoma, because it is insulin secreting tumor. Because when we proceed with the critical sample, insulin also was high. So any tumor was a suspicion. Also in view of hyperoxaluria and genetic proven, and if there is any association with genetic issues like any genetic cause of hypoglycemia, also we have thought of, or any because of the age group, any autoimmune antibody means against insulin antibodies. So we would thought of insulin autoimmunity also, sir.
So one question that will come to everybody's mind is whether this condition, because most of the pediatric endocrinology audience will not be I mean, it is far in their far remote memory or something of regarding oxaluria. So one question will come to the mind, that is there any correlation or association with oxaluria and hypoglycemia? That is the first question. Second question is that you rightly said that this is a totally previously normal child who is totally growing normally and doing everything, like every milestone, perinatal history, everything seems to be normal, and suddenly he has developed hypoglycemia. So in the apparently normal 10-year-old child,
Yes, sir.
Anybody developing suddenly hypoglycemia, and you rightly said that insulinoma is one possibility, but how does weight loss fit into that picture? I mean, what are the etiologies that could be associated with weight loss in hypoglycemia?
As insulin is an anabolic hormone, usually we are not thinking of his weight loss will not be there. But according to the history, only weight loss was there. But in the weight centile, everything was in the normal weight centile was, sir.
Yeah.
And his BMI was also adequate.
I mean, the only condition that I could think of was probably if somebody is developing an acquired adrenal insufficiency, there could be weight loss and there could be hypoglycemia both. Although that would be
Yes.
more of a
Yeah.
fasting kind of hypoglycemia, and it may not be very like it may be
Yeah.
very subtle, or I mean it may be just
Also, the
detected on
child was
testing.
very stable, sir. Also, the child was stable. There is no any how it was sent with normal, so we could rule out the hypopituitarism, primary adrenal insufficiency, and also.
Yeah. And another possibility is that if somebody is having a psychiatric problem, they could have issues related to appetite, as well as they could have issues related to medication administration. So these are the possibilities that one would think in association with weight loss and sudden development of hypoglycemia. Obviously, and what are the things that are less likely if a child was totally normal till 10 and now suddenly developing hypoglycemia? What are the things, what amongst the list of causes that you saw in Anna ma'am's lecture, what do you think would be unlikely or less likely?
Unlikely to be this genetic issues, like unlikely because the child was very normal and weight was adequate. So newborn period also there is no history of hypoglycemia. So genetic causes are unlikely. Also causes like fatty oxidation, acid oxidation also is unlikely, sir.
Okay, I think we will take Pratik's comment over that, but for now, I think you can continue with the discussion.
Okay,
Would you maybe Pratik can interject a bit in between, and would fatty acid oxidation be fine totally till 10 years and suddenly develop with come with hypoglycemia?
It's very unlikely.
Very unlikely. Okay. So I think we can proceed now. You have some material ready before you proceed to investigations. And just for the benefit of postgraduates or students, it would be always useful to have some sort of whenever you're discussing any case, before you go on to investigations, you should have some sort of a thought with regards to history and examination. Okay, please proceed.
One comment with that fatty acid oxidation defect. Usually they happen after prolonged fasting.
Fasting.
So the time to develop hypoglycemia is not there in the history. You have not asked
Yes.
when he had his meal. Maybe that little aspect is good. Usually fatty acid can occur later also. Some of them are milder, but they used to follow a prolonged fasting, which may not fit into your case.
Yes. From actually in the history, child is having increased appetite and child is taking frequently meals as per the parents last few months, ma'am. I will proceed with the evaluation, sir.
Yes, please.
So evaluation, critical sample was sent during the hypoglycemic event. Random sugar was 16, but the pH was normal 7.45 and bicarb was also normal and there is no significant acidosis. Serum ketones was low and it is hypoketotic, but the plasma insulin level were very high and C-peptide levels were also high, sir. And the lactate was normal and the cortisol was adequate, stress response was there. Also, the investigation, the primary hospital also revealed the insulin levels were high. Insulin and C-peptide both levels were high. So it is like probably an endogenous insulin secretion. Other investigations, including CBC was normal and the renal function was also normal, as he's also already gotten hyperoxaluria, and liver function was also normal. Ammonia was normal and the thyroid function to rule out any associated antibodies like hypothyroidism, it was also normal. So we proceeded with the PET-CT on the day 2 of admission to rule out any tumor, but there is a diffuse uptake with increased uptake. So suggested a possibility of necidioblastosis in the PET-CT. So there is not any tumor localizing lesion is not present in the CTs. So we proceeded with the initial management. We have given dextrose bolus 500 kg via peripheral line, and the repeat sugar improved to 52 milligram per deciliter. So we continued on dextrose with normal saline maintenance fluids, and we shifted him to PICU. And GIRA was titrated up to 8 milligram per kg per minute to achieve normoglycemia. Diazoxide was started from the local hospital. It was given 25 mg three times a day. So we increased to the dose to 50 mg TDS. It will come around 3.7 mg per kg per day. So the differential diagnosis we considered were any genetic causes of diffuse hyperinsulinism or insulin autoimmune syndrome or any metabolic association with primary hyperoxaluria. And insulinoma is unlikely as there is no focal lesion in the PET-CT also. So we have further proceeded with the investigations. Insulin antibodies were sent and it was in the normal range. Whole exome sequencing also was done to look for any association between primary hyperoxaluria and the genetic cause for hypoglycemia, but there is no association with hyperoxaluria and hyperinsulinic hypoglycemia in the genetic whole exome sequencing also. During the hospital stay, his hypoglycemia settled within for 18 hours after reaching to our hospital, and he remained glycemic, and the dextrose GI was slowly tapered and stopped within 48 hours, and he was shifted to ward on the next day, and we continued him on diazoxide 3.7 mg per kg per day, and we planned for discharge on day 5 of admission as he was off IV fluids and is tolerating feeds and no hypoglycemia during the event. But the same day as we planned for discharge, he developed repetitive hypoglycemia, which did not improve despite increasing the diazoxide dose to 75 mg TDS. It will come around 6 mg per kg per day. Also, he was started on octreotide 550 mics subcutaneously, and 2 doses of glucagon also was given from the ward. And his GER was increased up to 4 milligram per minute as through the peripheral line. But even despite all these measures, he remained to have hypoglycemia, so he was shifted back to PICU. So from the PICU, we have repeated the insulin levels and C-peptide. It was still high at the time of hypoglycemia. So GI requirement has increased. Previously, he was maintaining up to 8, but this time his GI requirement has increased up to 11 milligram per kg per minute. And we have increased the dose of diazoxide to 11 mg per kg per day. Despite this, hypoglycemia was persisting, so we were thinking on drugs other quality issues. We changed the brand of diazoxide also, and he was the octreotide was painful, so we switched off to continuous subcutaneous subcutaneous infusion of octreotide, and the dose was hiked up to 15 mics per kg per day. Rescue dose of glucagon also were used, and diet modification was done along with cornstarch. Cornstarch dose was initially we have given 25 grams, but we have increased up to 30 grams per day of cornstarch. Sorry. Every evening and night, child had nausea and vomiting with poor oral intake. So the hypoglycemia predominates in the late evenings and night. More likely, 1 o'clock, he started to have hypoglycemia more. There is no relation to the food, protein, or juice intake for the hypoglycemia events. So we were thinking refractory hypoglycemia. The only options left was sirolimus or neonatal pancreatectomy. We discussed with our pediatric surgeons also, but he was told like it's the last resort for the surgery because future it will be difficult to control this one. So a complete reanalysis of the case history was done before these major decisions. I'm audible, sir?
Yes, yes, you are.
So we have a hypoglycemia. What with the cause of hypoglycemia? We were thinking there is a weight loss in a child with hyperinsulinism. We expect the weight gain instead of weight loss. Recurrent abdominal pain. We have thinking of any functional because even even after appendicectomy, it was persisting. Family dynamics. There is a poor relationship between the stepdad and son. on examination, there is no hepatomegaly. There will be at least some mild hepatomegaly in hyperinsulinism. Even that was not there. There is no association, as per the genetic report, there is no association. We discussed with the geneticist also. There is no association between hyperoxaluria and hyperinsulinism. And initially the hypoglycemia settled within 1 day of admission, but again recurred as we are planning for discharge, the hypoglycemia recurred. There is an initial response to minimal dosage of diazoxide, but now even with the maximal dose of diazoxide, octreotide infusion and high GI requirement, the hypoglycemia persisted. Also, there is nausea and vomiting every night with predominance of hypoglycemia in late evenings and night. But there is no association with the prolonged fasting time. There is no hypoglycemia. Also, the child is taken care by, financially sponsored by a corporate company. There is no financial burden to the parents. Even after the caregiver responses appeared disproportionate to the illness severity, including immediate acceptance of surgical intervention and repeated request complete marriage within a single hospitalization. And they were willing for even the surgery, they were willing to, without thinking too much. So we were thinking any factitious illness. So we have parental restriction to the PIC was done, and no outside food allowed. GR from the GR 11 milligram per kg per minute, we came down to the GIR and we could stop within 2 days. Also, diazoxide was abruptly stopped on the next day to look for any hypoglycemia. Even after stopping diazoxide, also there is no hypoglycemia. So next we started coming down on the octreotide infusion also. We tapered from 25 mics to every 4 hours. We came down on 5 mics. And there is no hypoglycemia even on tapering also. So all the medical measures were completely withdrawn within the 72 hours. So it was like surprising for us. We could taper everything within 72 hours. And there is no hypoglycemia during the stay after this parental restriction. So the Munchausen by proxy, most probably sulfonylurea induced hypoglycemia were thought of. And he was hypoglycemic throughout off medications and off IV fluids. We have sought clinical psychology opinion was also sought. Diagnosis revealed to the parents, however, they did not confess any medication to this one. MLC was registered and child was shifted to ward and was hypoglycemic for 1 week and discharged without any medications for hypoglycemia. On 1 month follow-up also, child was asymptomatic. So as per American Academy of Pediatrics, there is a case report showing hypoglycemia is one of the top five most common presentation in Munchausen by proxy cases. Maybe the mechanisms include insulin administration, sulfonylurea ingestion, withholding food, or manipulating glucose samples. However, when we are provoked, this history thought of, but there is parents denied the giving any medications, but we couldn't check for the sulfonylurea levels also because already time was elapsed. So we couldn't check for the sulfonylurea levels also. So coming to differentiating factitious versus true hyperinsulinism. In factitious, there will be insulin will be elevated, but in case of exogenous insulin, the C-peptide levels will be low. But in case of sulfonylurea, both the insulin levels and C-peptides will be high, and it will be the positive sulfonylurea test screen will be positive. And hypoglycemia absent during supervised fasting. Episodes only with the caregiver present, there will be no genetic mutations and imaging will be normal in a factitious disorder. Whereas in true hyperinsulinism, there will be insulin will be high and C-peptide levels also will be high along with the insulin. Hypoglycemia can be reproducible during fasting and the GI requirement will be high. Also, sometimes they will get a genetic mutations, including the ABCC8 and KCNJ11 mutation. And in imaging, there will be focal or diffuse uptake in PET-CT. So, for the take-home messages here, refractory hypoglycemia in a child warrants a structured endocrine evaluation, including critical samples during hypoglycemia. There will be inappropriately elevated insulin and C-peptide during hypoglycemia confirms endogenous hyperinsulinism, but the etiology may be heterogeneous as per ma'am said. There is not all hypoglycemia is insulinoma or congenital hyperinsulinism. Late presentation and atypical cause should prompt reconsideration. Unusual and inconsistent glycemic patterns should rise for a concern for factitious hypoglycemia, and it is a diagnosis of exclusion. Early recognition is essential to prevent iatrogenic harm and to initiate safeguarding measures. Also, we have to register for the MLC because it should be initiated to ensure the patient safety, accountability, and to prevent recurrence of similar events in the future. Thank you.
So I think you deserve a big round of applause, you and Dr. Soundaram, for working up this case very, very meticulously. And also, many a times we do suspect factitious hyperinsulinism or factitious Munchausen syndrome by proxy, but it is a diagnosis which is extremely, extremely difficult to reveal. I mean, even to reveal such a possibility, one has to do it in a very, very careful and very sensitive manner, probably with couple of evidences. I mean, a couple of people standing in your room, or with a very good documentation, and one has to be absolutely sure that this is the possibility. So I think it's a very, very delicate diagnosis, and you've handled it superbly well. So really, congratulations to you. I think the question also relates the same. That how were the parents confronted? Were there any other authorities such as child helpline involved? Unfortunately, unlike in Western countries, we don't have structure to this about how to go about. So Fatima, would you like to answer that question?
Parents actually denied any medication intake, but even without 72 hours, child was in the PICU without any medications. There is no repeated episodes of hypoglycemia, but unlikely the thing is we couldn't check for the sulfonylurea levels because initially because he was on medications, we were coming down slowly, and we were thinking if we could come down, but already 48 hours was over, so we couldn't check for the levels. It will be even if we are sending, it will be falsely low, so we couldn't send the levels. And even though parents has denied, but there is no recurrent episodes of hypoglycemia. Also on the 1 month follow-up also, there is no evidence of hypoglycemia throughout, so that we have registered for the MLC also. So since the MLC, parents might have got a fear in their mind, so they couldn't give again.
Yeah. I think that's why they say that whenever we collect critical samples, we should always preserve one extra plain blood sample and extra urine sample, because all sorts of testing may be required afterwards. And Pratik, I was going to come to you for your comments, and I have one specific question for you with respect to DOPA PET, because I don't think that it's extremely it's not 100% sensitive test. So your comments on the case as well as a utility of DOPA PET for insulinoma, about how good a test that is.
Yeah.
But
Thank you very much,
Yeah.
Yeah, Pratik, please.
No, go on, Fatima.
No, if it's like any localized lesion, we could get in
This, of course, if there is a localized lesion, you would say that it is. But whether absence of such a lesion, does it totally rule out insulinoma is the question. So, Pratik, your comments?
Will not rule out completely.
Yeah, you're right. So thank you very much, Fatima, to share this case, because I was very much involved with this case. So I had lots of discussion with Dr. Soundaram. We've had a lot of phone calls. And there are quite a few things that I would probably like to highlight. I've actually asked her that, this should be actually published, but there are quite a few things that were, just didn't make sense. One was initial diazoxide responsiveness, and then there's no diazoxide responsiveness. We even changed that brand of diazoxide. And also then you kind of have a stability period and then suddenly start having hypos. And, I always, we always had this discussion is, can we just stop everything and revisit this? Because sometimes when you really get stuck and you're not sure about what's going on, it's best to stop everything and then you restart your investigations. because I've had discussion with my geneticists. I mean, I looked at literature. There was no evidence of hyperoxaluria associated with hyperinsulinism. We thinking about some weird syndromes or weird conditions about when you think about hypoglycemia, and at that time obviously there was no indication of having kind of factitious illness. And you kind of think about like, yes, there might be something that we may be missing. Are we dealing with something very unusual condition? Yes, MRI or any imaging, even PET scan, I may not really rule out. If it's normal, may not rule out insulinoma. So if you are suspecting it, yes, sometimes it's always good to really stop everything, stop all the medications and revisit that. And the only way to do it is by doing fasting tolerance, by thinking about, because also there are times when this child was completely off IV fluids and suddenly you had to go back on IV fluids, which kind of also makes sense. Is what is it that, when the child was responding to medication and then now you have to go back to IV fluids. Also this, the C-peptide and insulin, which is also very difficult to analyze and see what exactly is going on. So yeah, in cases where you may not be sure about, sometimes it's good to just revisit everything. So I would say very well done, to actually come to the diagnosis, because it was really difficult to understand. And it's very commendable, and I think it's a good learning point. And I actually did say to her, I think this is a very good learning point for everybody else, and maybe it is worth just reporting this as well.
Yeah.
We have
Would you like to comment on the dopa PET?
Dopa PET. So in terms of diagnosing insulinoma,
Yeah.
yeah. So it also depends on the radiologist, and it may not be 100% sensitive. I mean, we use dopa PET or gallium hexandin per se, but we have found that sometimes radiologist reports as normal, and when it is shared with somebody else, it actually is reported that they have diagnosed insulinoma. So it does depend on the the person who is reporting it, also how it is undertaken. But yeah, it may not be 100% sensitive.
Question for Fatima: were the parents having diabetes or taking sulfonylurea?
No, both parents were not diabetic, sir.
Okay. And Aruna has asked a few questions. Can we do HbA1c to look for persistent hypoglycemia? I'm not sure how good the test will be to really suggest hypoglycemia, unlike hyperglycemia. So I don't think it's going to add anything. And particularly, this child was totally normal and has developed like a very recent onset or new onset kind of hypoglycemia. In this particular case, I don't think it will be any use. Do you agree, Fatima and Pratik? And another question is, it's a heterozygous variation that you've seen in this child. Can't he just be a carrier for primary hyperoxaluria? Is it? To be honest, I have forgotten. It's in my remote memory, this diagnosis. I mean, I've heard this name, but I don't know what is primary hyperoxaluria. So, and I didn't even bother to read it since the case was known to me. But would you like to comment on this?
Yes, sir. Child had history of hematuria also. For that only evaluated for hyperoxaluria. So family history of hyperoxaluria also was there. And it was like type 1 for the father. And type 1 is usually the severest form of hyperoxaluria. It will present with CKD, and usually patients will end up on dialysis and renal transplant. Even renal transplant will not protect from the hyperoxaluria for type 1, or combined liver and renal transplant has to be done for type 1.
But the question is, if it is an autosomal recessive condition, this child had a heterozygous variation. So does it mean that there was another variation sitting compound heterozygous, or which has been missed or which has not been detected or anything like that? And there's another question: reverse phenotyping to do urine microscopy to look for oxalate crystals. This is actually I would say that this is more of a pediatric or metabolic or renal kind of a question. So maybe Fatima can answer this. And I think we are running out of time, Jalak, if I'm right.
Yes.
So maybe you can answer these questions in the chat box, Fatima, some of these questions.
Okay, sir.
I think we have had a wonderful case discussion, and after this, we would go on to listen to Dr. Prateek Shah, whose I would say physical body is in UK, but his soul is here. So his formal introduction is mentioned here. I'm very happy to have interacted with him. I think we got to interact more in the recent ISPAE at Nagpur. And I would say that that was one of the most significant achievement of ISPAE Nagpur. He is a consultant in pediatric endocrinology at Royal London Hospital, and one of the key thing that I would like to highlight is that he is right now working on molecular basis of non-diabetic hypoglycemia, and this is something which is of practical importance to us, idiopathic and pathological ketotic hypoglycemia. So if we have cases, I think we should get in touch with Dr. Prateek because they are accepting samples for this. I would not waste any time further. Over to you, Dr. Prateek, for your talk.
Thank you so much, Ganesh, for the introduction. Thank you, Jalak and Anurag, Dr. Anurag, for the invitation and the ISPAE ACES team. So I'm just going to share my presentation. Oops. Okay, so am I audible? Is that all right?
Yes, Dr. Prateek.
Okay. So thank you very much. So this is my disclosure. So what I'm going to do in the next 20 to 25 minutes is going to just give a quick overview, and Dr. Anna Simon has given a really nice talk about and set the scene that how do you really investigate and diagnose, but just a couple of slides for that. And then I'm going to talk primarily about 3 conditions, which is what is more important for us as an endocrinologist, is hyperinsulinic hypoglycemia, and just touch base with some newer medications, then talk about some pituitary disorders, growth hormone deficiency and adrenal insufficiency. And then I've got some cases just to kind of have some interaction. I'm happy for you to put your comments in the chat box during cases. So when we talk about hypoglycemia and an investigation, it's really, really important that, when would you investigate, in history and clinical examination, extremely, extremely critical. But you always then think about recurrent hypoglycemia, and especially when children present with recurrent hypoglycemia. So you think about either ketotic hypoglycemia, especially when children are unwell and they present with hypoglycemia. And I've put here as think about pathological idiopathic ketotic hypoglycemia, and is because we are currently doing research and trying to understand a bit more about this condition, where there are genes implicated in causing this condition. And then we talk about non-ketotic hypoglycemia, specifically like congenital hyperinsulinism. So, Dr. Anna had shown a really nice fasting kind of testing times. This is what we use at our hospital. And we generally try and determine as how much, this child can fast for. And the reason I'm kind of showing this is because your treatment is very much relying on this fasting tolerance. So I cannot stress any more importance is that, when you are determining a response to a treatment, think about doing a fast test, or ask parents when they are checking blood glucose at home is, what is the fasting tolerance? And this is a rough guide. I know that, in the book, which was mentioned, that they have recommended like a prolonged fasting in infants or newborn, which is up to 18 hours, which is obviously very, very, hard to do it. And you would normally not do it. So you also have to think about what is physiological. So this is what we do, and maximum we do, I mean, though we have said more than 8 years as 20 to 24 hours, but generally from practical point of view, we would fast for 18 hours, determine whether they have hypoglycemia, and if they don't have hypoglycemia, we kind of say they are able to fast for at least 18 hours. Because normally you would not see children anyways fasting more than 12 to 14 hours anyways. So very important to do a diagnostic, setup. So making sure you got everything ready before you take the blood samples. And that is the reason why we want to do this, is because sometimes we have to go back and just revisit everything. And that was the second case which was just presented, is sometimes when you're not able to understand that what is the reason of hypoglycemia, please consider starting from scratch.
May I
Because that,
interrupt you for 1 minute? I think there's
yeah,
a message that slides are not being seen. I am able to see it. Can one or two people confirm if slides are being
We are
seen?
able to see.
Okay, okay. Then maybe Dr. Sudha had messaged that she is not able to see the slides. Maybe she can log out and log in again, back maybe.
so shall I start?
Okay. We are able to see.
Okay.
Maybe some. If 2, 3 more people are able to see, then we can just proceed. Sorry
Okay.
for the interruption.
No worries. No worries. Thanks. So when we talk about, investigating and when we want to know what is the reason of hypoglycemia, now there are numerous causes of hypoglycemia. In particular, what we are interested in is, obviously I've mentioned about idiopathic pathological ketotic hypoglycemia, and we are actually trying to look into reasons for those. And now we've also identified, as Dr. Anna Simon has highlighted, about syndromic causes, and very, very important to think about those. But in particular, we talk about, like, for the purpose of the talk, I'm just going to talk about hyperinsulinism and growth hormone and adrenal insufficiency. So when these are the two things that we're, just for the purpose of today, we're going to talk. When we talk about treatment goals, so when you are trying to manage these children, what is your treatment goal? What would you like to achieve in terms of blood glucose levels? Now, for non-ketotic hypoglycemia, which is hyperinsulinism, we would generally recommend blood glucose of more than 63. Now, that's the standard that we have, used in the UK and EU and Australasia. Though our international hyperinsulinism guidelines, we have recommended, which is typically what US prefers, is higher than, more than 70 milligrams per deciliter. But in ketotic hypoglycemia, especially if you have children with glycogen storage diseases or fatty acid oxidation disorder, or especially or growth hormone deficiency or cortisol deficiency, we would recommend to have blood glucose of more than 54, which is and some units use as 50, which works out around 2.8 millimoles per liter, which is what some of the metabolic people uses here in the UK as well. So I would say anything above 50 or even 54 would be your treatment goal for ketotic hypoglycemia. I just wanted to highlight this couple of slides on hypopituitarism. And it's been very well known that the first case was published about 50 years ago of ketotic hypoglycemia and hypopituitarism. So it is a very well known associated condition about children with hypopituitarism presenting with ketotic hypoglycemia. And when we do hypoglycemia screen, both the cortisol and growth hormone, they are counter-regulatory hormones, but the low levels doesn't really mean that they are having the problem. We have to obviously investigate further. So it is very, very important that low levels doesn't necessarily mean that they have the condition. So it's important that you investigate further. And I've just highlighted some of the papers that we've published, and where we have shown that hypoglycemia was very much part of the presentation in these conditions, where they had either a growth hormone releasing hormone receptor gene, or with EIF2S3 or FOXA2 mutation. So some of this can have hyperinsulinism, but some of this can have hypoglycemia associated with growth hormone deficiency. And then coming to adrenal disorders, again, first case was published about 50 years ago, more than 50 years ago now, where they published about ketotic hypoglycemia with adrenal cortical insufficiency. So it is very well known that children with recurrent hypoglycemia, children with adrenal disorders, can present with recurrent hypoglycemia, especially when they are unwell. And I would like to highlight this because this is how I had one case, and we published this over 25 years of experience in the UK with primary adrenal insufficiency. And one of my patients had CYP11A1 mutation, where they were from Turkey, and this child was typically presenting with hypoglycemia when the child was unwell with diarrhea, vomiting. We did a cortisol level, and numerous times the cortisol level would come as, I mean, I would not know the micrograms per deciliter, but we used nanomoles per liter, which was around 230, 240, which we would consider as normal. However, at those times when we would present, when we would do with, at the time of hypoglycemia, you expect sometimes to be slightly higher, which is what we would expect around at least 350 to 400 nanomoles per liter. But what had happened was that we did an ACTH, and ACTH came back as really high. And subsequently, then we did a synectin test, and we found that this child had suboptimal response to synectin test. And then we found where the family was. We then had some patients already with CYP11A1 mutation from that part of Turkey, and then we did a whole exome sequencing and found that. So very, very important to think about of the history and management. So the standard of care management is always remember stabilization. Now, obviously, you try and take samples, critical samples of hypoglycemia screen, which is very, very important. But please, if you're not able to get those samples, do not really try taking and spending too much of time in taking those samples. You can always revisit or do a proper, appropriate, fasting test to do the critical sampling. So obviously try and stabilize the baby or child as soon as possible. Frequent blood glucose monitoring, really important, like I mentioned, in terms of what your blood glucose cutoff should be. So if you're suspecting hyperinsulinism, aim to have at least more than 63 milligrams per deciliter. But if you're suspecting ketotic hypoglycemia, then at least more than 54 milligrams per deciliter. In terms of medical therapy, obviously with other conditions, you probably would be able to use start IV fluids and then you manage as per the underlying cause. Yes, if you have ketotic hypoglycemia and if they are unwell, you just have to wait for them to get better and gradually wean fluids and make sure you monitor blood glucose, and they should be able to maintain blood glucose levels. However, if you're suspecting hyperinsulinism, then yes, the first line of treatment is diazoxide. I would always recommend that you start diuretics, especially in infants or neonates and infants, because of the side effects. And typically the rare side effects, which is pulmonary hypertension. We also recommend in babies or to do a bit of fluid restriction, which is around 130 mL per kilo per day as a total fluid requirement in babies. Nifedipine is a calcium channel blocker, which is not regularly used. However, there are reports that it is used in conjunction with diazoxide, and sometimes it has helped. And then the next step, especially this is in more of a neonatal period, and I know we are talking about postnatal period, but sometimes you may need to use this in older children as well. And you may have to give octreotide or glucagon infusion. Now, glucagon infusion is really helpful, especially you can give as a subcut infusion. So if you're not able to get a cannula, you can start a subcut infusion as between 2.5 to 10 mics per kilo per hour. And then you've got octreotide, which is given as a subcut infusion or injections. Please do not use IV. So I've put in capitals as use subcutaneous only, because from time to time I do come across that, we do, sometimes I've come across that if clinicians use as IV, and it's just mainly because of the risk of necrotizing enterocolitis. And then nutrition and feeding becomes really, again, very important. Like with the first case, where sometimes we just have to try and manage with a little bit of feeding management, or how how we feed the child. But also sometimes we have to do fluid restrictions, or we may need to do a feed supplementation, like with Maxigel or Vitigel. We use SOS in the UK, which is just a glucose powder. So especially this is very helpful in ketotic hypoglycemia. So I'll come in sort of later slides about the hypoglycemia plan. So all the children should have a hypoglycemia plan for home, but we use this especially in terms of sick day rules, especially when they are unwell. Now, I've mentioned about a bit of genetics and how do we differentiate between in terms of focal and diffuse form in hyperinsulinism. And the reason I want to mention this is because your management will be, it will be relying on what you actually find in terms of your the genetics, as well as whether it is focal or diffuse. So we generally try and send off genetic samples if they have diazoxide, or if their diazoxide dose is more than 7 milligrams per kilo per day. And primarily, we obviously want to rule out, having KATP channels. So typically, If the child has got a recessive or a dominant form, which is from maternal side with KATP channel, then it's diffuse. However, if they have a paternal inherited KATP channel, so inherited from father, then they are likely to have focal lesions. So, and that is why it is really important to try and get the genetic testing done. I always suggest that if you can ask your lab to just do KTP channels first, because that actually helps us to make decision quicker if they need to do have a further imaging. And the imaging obviously is like we've discussed, again, using of 18F-DOPA PET-CT, which is a standard of care that we currently use. However, we're now increasingly using gallium exendin PET-CT, and we've also found that similar in our current studies that gallium exendin PET-CT can be more sensitive and specific compared to 18F-DOPA. So when we talk about, the management in hyperinsulinism, now we always struggle, that what if they are not responding to the standard medication? And unfortunately, right now we only have one oral medication, which is diazoxide. So when we are using newer medications, I always suggest please speak to parents about it, because, one, we do not have long-term data or safety data of any of these medications. So it's very important that we discuss and counsel the parents before we start any newer medications. So obviously, we've been using octreotide, which is sort of daily injections for some time. However, now over the last several years, we are now using long-acting octreotide or long-acting somatostatin analog, which is given once every 4 weeks. And what we generally try and do is we start this medication after 3 to 6 months of age because of the side effects, and we do not want to start those in sort of early in life, especially because of the risk of necrotizing enterocolitis. We also reported about use of mTOR inhibitors like sirolimus, but it's a immunosuppressant. Again, very important for us to think about when we really need to use this. And if you are using it, please make sure you monitor very closely for side effects, as well as the blood levels of sirolimus, because the dose is titrated based on that. We published our long-term experience with sirolimus, and we found obviously, most of the children had severe side effects. So we just have to be mindful about when we are using it and try avoiding using it for a very long time. There's GLP-1 receptor antagonist, which has been used especially in the US, but it is given as an IV infusion. So it is only used in hospital setting, which is, not something that you can discharge child home on this treatment. And now there are several clinical trials that is going through over the last several years. Unfortunately, none of this has come out yet as a full approval or an FDA approval of using this. So dasiglucagon is given as a continuous glucagon infusion via the pump, insulin pump, and it is a more stable preparation than compared to the standard glucagon that we have. Second one is RZ358, which is an insulin receptor antibody, and they are looking into approval from FDA soon. Hopefully, we will get some news soon. And then we have HANMI, which is another form of glucagon, it's slightly long-acting glucagon, which is currently being looked into. And then there is another oral drug, which is a somatostatin receptor 5 agonist, which sounds a bit promising, but we haven't really had much update about this. So it's a somatostatin 5 receptor agonist, which was an oral formulation. And then there are a few other drugs that are currently being looked into. Now, coming to long-acting octreotide or lanreotide, more importantly is, like I mentioned, it's given once every 4 weeks. The dose depends on your daily octreotide injection, then you times 30, and that will be your monthly dose. And lanreotide, if you're using, then use 30 to 60 milligrams every 4 to 6 weeks. But again, the side effects are very important to monitor, and they are very much similar to what we have as an octreotide. Sirolimus, I've just gone through, the effect, but very importantly is to make sure the dose that you have start at 1 milligram per meter square per day, and please try and titrate the dose based on the trough levels. So we usually do a trough level before the dose. and make sure you kind of achieve. Now, this 5 to 15 nanograms per ml is something that is used by oncologists for immunosuppression. So you remember that you're actually you're achieving immunosuppression with this dose. This is just a recent paper which we published, just to kind of talk, where we've spoken about all these new drugs and the doses as well. I would just like to mention about alpelisib, because recently we've had this discussion when I was in India. Recently, there have been some case reports about using alpelisib, which is a PIK3 kinase inhibitor, which is actually used in cancer treatment, especially breast cancer overgrowth syndromes. But what it shows is that PIK3 kinase inhibition can reduce glucose transport and increasing glycogenolysis and gluconeogenesis. So there were two cases with severe hyperinsulinism where they were not responding to conventional therapy, and they had trial alpelisib with some response. But again, side effects and long-term safety data is not available. And then coming to the other treatments, obviously, when you're trying to manage medically, our first aim is to try and manage medically. But what about if you can't? So obviously, if those who have focal lesion, you will obviously do a surgery like a focal lesionectomy, and trying to identify the focal lesion is really important before obviously we undertake that. But those with severe diffuse disease where they don't respond to medical treatment, they will need to have a neonatal pancreatectomy. It's very important to have discharge planning. And like I said earlier as well, please think about doing fasting tolerance test. And also when you see them in clinic, it's important for us to regularly think about whether the fasting tolerance is improving or not, or whether we need to optimize the medication doses. And again, sort of long-term follow-up in terms of neurocognitive deficits is really, really important. And coming to other causes of hypoglycemia and especially with growth hormone deficiency. Now, I've mentioned about that we've seen children with growth hormone deficiency can present with hypoglycemia. And sometimes we have to use growth hormone, especially in very young children. Have had to give growth hormone as twice daily injections rather than once daily. But now there is also increasing sort of research about long-acting growth hormone. I'm sure you guys have all used that in India. But whether we can use this in children with hypoglycemia, especially with the growth hormone deficiency, and there's not much data about that yet at the moment. So think about when you're using it, it's very important to monitor this, because this is given as a weekly injections. But again, fasting tolerance is really, really important. And at the moment, we are not using, if there's children with hypoglycemia, we would not really use long-acting growth hormone because we don't have much data. But again, just to think about that. And then we have with adrenal insufficiency, where we obviously use hydrocortisone. But again, there is research about modified release hydrocortisone, which is given either as once or twice daily, where you try and mimic the circadian rhythm. It's not yet available in India, but I know that there is a lot of discussion going around when discussing with the companies. But I think, again, there is some, what I was told is there is some glucose regulation improvement in adults with adrenal insufficiency and hypopituitarism, but there is not much data on children using this modified release hydrocortisone. Obviously, this helps in terms of compliance because it's only given once or twice daily. So I'm going to go through some cases in the next few minutes, and then I'm happy to take some questions. So I just want to have some interaction. I'm very happy for you to put on the chat. I may not be able to see the chat, but just let me know, if there is any answer. So we've got a first case is a term baby, normal birth weight, required some resuscitation at birth. Born to a primary gravid mom, normal antenatal scans, and no significant family history. Was diagnosed with neonatal GBS meningitis. So had a severe brain injury and developed a severe neurodevelopmental delay. So this child had severe gastroesophageal reflux and required feeding supplementation. So then eventually went on to have Nissen's fundoplication and PEG insertion. So on further monitoring, when the child presented around 1.5 years of age, presented with seizures, had investigation for seizures extensively, had MRI, EEG, everything, but they were not able to find, but was started on anti-epileptics. At 2 years of age, was on multiple anti-epileptics due to refractory seizures, and then presented again with prolonged seizures at 2 years. And someone just did a blood glucose at that time, and they found that they did a pre-feed blood glucose, and they found the blood glucose was low on 4 hourly feeds, which was around 40 or 38 milligrams per deciliter. So interestingly, we obviously did a fasting test, fasted for 14 hours, did very well, and that's why I was trying to say that sometimes we have to think if this is postprandial hypoglycemia. So in this case, we had a child with likely postprandial hypoglycemia. So went on to do OGTT, or a mixed meal test, and we found that there was detectable insulin, and low fatty acids, low ketones, and low blood glucose concentration. So it had normal cortisol. So you had this case of postprandial hyperinsulinic hypoglycemia. And the first thing would be very important is to look at the feeds, and can you actually modify the feeds? And then if they do not respond, then you think about other medications. And the first line of treatment would be either diazoxide, or you can even try acarbose. Case 2, have I got a couple of minutes, Ganesh? Is that okay?
Yeah, Pratik. It should be fine. Yeah.
Thanks. So case 2 is a 4-year-old with presented with diarrhea and vomiting. This was a third episode of hypoglycemia when unwell. There was a paternal history of type 2 diabetes, and paternal grandmother had type 1 diabetes. Very normal pregnancy, normal delivery. And they did a blood glucose which was low, which was 17 milligrams per deciliter. But unfortunately, at that time, they did not do point of care ketones at that time. So was admitted on the ward, and then had further hypos on IV fluids. So started on IV fluids. But when they looked on the height and weight, it was pretty much as normal, with a midparental height as 25th to 50th centile. So when we did all the investigation, they managed to get the hypo screen done, and it came back as that cortisol was a bit low, and no growth hormone was also a bit low. Now, again, like I mentioned earlier, that when you do hyposcreen, this is very typical, where you see insulin was less than 2, as what we say is undetectable. The fatty acids and ketones, so we generally would say anything more than 1.5 of fatty acids and ketones is raised. So in this case, you've got raised fatty acids, raised ketones, but they both are raised at the time of low blood glucose levels, and insulin was as low. So you got like a case of ketotic hypoglycemia. Now, obviously, you have to do a full metabolic workup, but you see that cortisol and growth hormone, they both were low. But when you look at the history, the weight and height looks fine within the range of mid-parental height. So we also then sent off, screening for urine organic acid, acylcarnitine, plasma amino acid, which came back as normal subsequently. But when we then did it, most of the times we end up doing synectin tests in this kind of situation. So we then went on to do baseline pituitary function, including IGF-1, HGH, and cortisol. And we did a synectin test, and that came back as abnormal. So you could see that the peak cortisol, we use nanomoles per liter. We generally would say anything more than 420 as normal. But you could see that I'll put in micrograms per deciliter here, but the cortisol on synectin was abnormal. So went on to have MRI and showed that the child had small anterior pituitary and absent posterior pituitary. So again, the standard treatment would be hydrocortisone, maintenance hydrocortisone, then following for growth and thyroid as well. One of the things I always again tell my resident doctors is we haven't really given information about the height. That the height was, though it was on 25th centile, but what was the previous height? Now, if the height was on 75th centile and the child has actually dropped the centiles as well, that will also make you think about whether this child has got, growth hormone deficiency. Third case is, we've already discussed this, so I'm not going to go a lot, but this is an insulin receptor mutation case. And I just wanted to kind of say that this is about 3-year-old girl who actually presented with hypoglycemia. And we investigated this child a lot. And when you think about, we did on examination, this child had some acanthosis of the neck, but did not have any raised BMI. And there was also a history of, neonatal hypoglycemia, but which got better. So when we did a fasting test again, so the fasting test showed that the glucose was around 50 with insulin, raised insulin, and bit of low fatty acids and ketones. So see, this child did have hyperinsulinism, and when we fasted for about 12 hours, and she had a hypo. But we went on to do OGTT as well to understand a bit more about this because of the acanthosis, and was found to have insulin levels of more than 300. And you can see this is one of the things. And again, we've published this case from Ahmedabad in ISPAE journal about very much similarly where the insulin levels were very raised. So one of the things where you also have to think about insulin receptor is that if you have a very high insulin levels, especially very like high this, then you think about insulin receptor mutation. And obviously the rest of all the bloods were negative. So we published this case. I'm still following up this child. This child is now 15 years old. But currently we are managing. So this child has now developed diabetes. So initially I had this child had a fasting hypoglycemia and postprandial hypoglycemia and now has developed diabetes. But again, the treatment would be his dietary management. We were managing with Ecobos and cornstarch. Initially I did not have to give diazoxide, and now she's on metformin. And then I would just like to mention this one case about hypoglycemia, which is hyperinsulinism, but a 10-month-old who presented with hypoglycemic seizures post feeding. And very important, again, the history was that woke up at 7 a.m. and had his milk. And then first time he had some mashed egg with pure at 11 a.m. And then he had seizures in the afternoon. So very typically is that this child had some food to eat and then had seizures. So when we did the hypo screen, it did confirm that the insulin was detectable with low fatty acids and low ketones. But one of the other things you have to think about is other markers, and the ammonia came back as raised. So obviously you do lactate and ammonia, but the ammonia came back as raised. So you think about what is the likely genetic cause, and the likely genetic cause is GLUD1, which is causing hyperinsulinism and hyperammonemic syndrome. So to summarize, persistent and recurrent hypoglycemia should always be investigated, and think always of factitious illness, as we have seen in the last case. Low cortisol and growth hormone at the time of hyposcreen is not diagnostic always, so it's always important to investigate. Early recognition and prompt treatment is very vital. In hyperinsulinism, it's very important to differentiate between focal and diffuse form, and please do genetics before you do imaging. Undertake fast tolerance test to assess response to medications. There's always a discussion about role of continuous glucose monitoring, and always think about, side effects when trialing new medications. And I've just got this couple of slides about what the hypo plan looks like. So this is a hypo plan that we use for children with CHI, and this is a hypo plan that we use for children with non-CHI. So you can see the cutoff is 3 or 54 milligrams per deciliter, and for HI we use as 3.5. Thank you very much.
Thank you, Dr. Pratik, for that wonderful lecture. Do we have any questions by any? I can't see any new questions except for your praises about your presentation. Anybody else has any other questions? Any other panelists? Dr. Anna, would you like to comment anything? So I was writing to you yesterday or a day before yesterday, I think, about, although we learn a lot about recent molecular advances and newer therapies, but when we are actually managing the hypoglycemia child, I mean, it is really a tough job with respect to the diagnostic tests also, because for example, many of the tests may not be accessible to people. What are the tests that have to be absolutely done on a critical sample? What are the tests that can be done, maybe the sample that is obtained a little later, or on a random sample, because sometimes you may not really end up getting adequate sample. So how should we optimize that particular sample?
So that's really useful, and we've actually created a flow chart, which I'm happy to share. But basically, insulin, C-peptide, fatty acids, ketones. So we also do point of care ketones now, and lab glucose. That is absolutely critical. If you can get growth hormone and cortisol, even better, because if you get high levels or normal, levels, then you know that you've ruled out that condition. But rest of rest of the blood, if you're not able to do it, you can do it later, which is obviously ammonia, lactate, But plasma amino acids, acyl carnitine, urine organic acids, they all can be done at normoglycemia. So yes, if you want to rule out fatty acid oxidation disorder, the only way is to do a prolonged fast. But it also helps when you do urine organic acid or acyl carnitine levels.
And has the availability of genetic testing changed anything with respect to these diagnoses? Because what if one sends, let us say, exome sequencing or something like that
No, I don't think. Yeah, I don't think we would
before
do
you do the
exome
fasting
sequencing.
challenge? Or
I don't think we would do exome sequencing without knowing it, to be honest. So we do need to confirm ketotic hypoglycemia. So, because of all these weird genes which we come across, but then to really understand whether they are significant or not, it becomes really difficult.
Okay. I think there is a very practical question. You've mentioned about 12-hour fasting. How do you make sure that the kid is fasting for 12 hours?
I know. So I think the fasting test, what we generally do is we start fasting after dinner. So we ask them to have a good dinner around 8 or 9. Most of the children do sleep for 8 to 10 hours. Okay. So if they are able to do that, what you have to just do is, can you just delay the breakfast by a few hours? So we always try and avoid the breakfast in the morning. So they start fast around 9 or 10 in the night, and then we try and finish the test around midday. 11 or 12. So if you want to do a bit of prolonged fast, so we just have to ask them to skip the breakfast, and they can have water during the fast test, but nothing else.
So starting late in the night or starting in the night, it's will
After
be
dinner, yeah.
kind
I
of
mean,
helpful.
yeah, because they obviously sleep for 8 to 10 hours overnight, so generally they are okay.
Lastly, one more question that I have is, we don't have suspensions of diazoxide, and invariably we end up,
Yeah.
doing some jugaad of using the capsule, breaking, I mean, or
Yeah.
breaking the tablet and dissolving it in the water. So how, I mean, although we do seem to manage at least some of our cases, I mean, many of our cases like that, but what sort of a role does a diazoxide preparation, as we mentioned as we saw in Fatima's case, there was some doubt
Yeah.
about diazoxide quality or things like that. So any comments on
It's
that?
true. So I think right now we're kind of looking into that as well, and that's what something Congenital Hyperinsulinism India Association is what very keen to work on with ISPAE and other organizations like NNF to try and work out how we can really make sure. But currently, what I understand is the tablet form that you have, people do actually um, people do use that as mix it in liquid and then they try and use it. But the
Yeah.
problem is nobody has done a stability studies on this, so it is really hard. So I guess we can all share our experiences, and that's how we probably learn from each other. But I've also spoken to the companies about making sure they do give a tablet cutter, because they come in 50 milligram tablets, for example, and it's very hard to make sure, to cut it. So now they're going to give tablet cutter apparently as well. And maybe consider doing some studies on this.
Stability.
Yeah, stability.
So, Dr. Zalek, do we have
So
one
can I
minute to take comments by Dr.
can I
Anna?
make a comment?
Yes, yes, ma'am.
Yeah, so what we do is like what Dr. Pratiksha said, we start at 10 o'clock in the night. We ask them to take something at 10 as well, apart from their dinner. And then we keep some nurses or one of the fellows or PGs who supervise them, and we try to keep away all food away from them. And we have gone up to 18 hours, 24 hours without a problem, making sure that they're fast. Second, with this diazoxide suspension, what we do is our pharmacy will give us a suspension syrup. So we just dissolve one capsule at a time and then divide that into portions so that it is stable for a day or so. And so we are able to manage for small children who can't swallow the tablet in those ways of reconstituting it just for the day.
Yeah. So I think we can pause here. We've had a wonderful discussion on both the cases and both the expert speakers. I think probably I'll thank again Dr. Jhalak and Dr. Anurag for giving me this opportunity, and I'll hand it over to Dr. Jhalak and Anurag.
Yes, Anurag sir.
Thanks a lot, Dr. Pratik, for a wonderful session. You really took us through all the various aspects of clinical management, the novel therapeutics and the novel options while keeping grounded on so many interesting case scenarios. So I think that approach was really wonderful. And it's been a very wonderful 2-hour discussion that we have been having on these two cases. Right from the beginning, Dr. Anna and Dr. Pratik have really highlighted the scenarios. Dr. Ganesh and Dr. Sirisha have really brought out a lot of interesting scenarios from those cases. And I'll definitely like to thank Dr. Jhalak, who has been the backbone with regards to this program. And she has been working tirelessly. And she's already messaged me about the next session, which is going to be done in June. So she's so proactive on that. So I think that she's keeping this session really doing a lot of good work on that. And thank everybody, all the participants who have come on this day. And we'll be joining again in June. So over to you, Jhalak, for the closing remarks. Then.
Thank you, Anurag sir, for always guiding me. The topics and the speakers, everything is the idea is of Anurag sir. We thank all our experts today. Professor Anna Simon, thank you so much for joining from Vellore for the wonderful presentation on the assessment of hypoglycemia. It's a privilege to have you. Thank you, Dr. Pratik Shah, to join from London. He's always available, just a phone call away. Whenever we are stuck with any case of hypoglycemia, we message him or call him, and he's always available. Thank you so much. And thank you for enlightening us on management of hypoglycemia and all your inputs today. Thank you to our mentors, Dr. Ganesh and Dr. Srisha, for guiding our presenters so well and leading the discussion today very well. Thank you, Dr. Dolly and Dr. Fatima, for the wonderful case presentation. You did very well. Thank you to all the delegates for joining today. Thank you, RX Events, for a very smooth proceedings. Thank you, everyone. Good night.
Thank you, Zalak. Good night.
Thank you, ma'am.
Thank you.
Good night.
Bye-bye.